All right, we'll go ahead and get started. For those of you who haven't met me, I'm Taylor Conrad. I'm the EMI MCCM Fellow for this year. And today we're going to talk about the oxymoronic title of non-cardiac EKGs, although probably a little bit more accurate than this, the electrocardiographic manifestations of non-primary cardiac problems. Obviously, right, we see so many EKGs, almost every single patient in the ER, we're going to see EKGs. And oftentimes we spend a lot of times of the primary cardiac issues of it, but I wanted to focus on some of the other things that we might see. And we'll have about 5 cases that we'll talk about for that. So this is going to be very interactive. I'm going to give you a pretty limited, very limited history at the very beginning. And we're going to go through a couple of EKGs for that patient. And then I'm going to ask people to interpret some of the findings that they find on there. And then we'll kind of summarize and develop a little bit of a differential for it and see kind of some of the things that we're going to think about. This is not meant to be completely all-encompassing. I can't cover all of EKGs or even this topic in 30 minutes, but hopefully we're going to focus on a few high-yield things that we'll often see in our training and in our practice. So case number 1 is going to be a 38-year-old female with acute dyspnea, right? So obviously this is an incredibly wide differential. I'm not giving you much other information. I'll give you a little bit more in a little bit, and we'll go through an EKG. So that is the chief complaint, and this is the EKG that we see. So could I get a couple people to point out 1 or 2 things that you see on the EKG? I'll give you a minute. Raise your hand, please, if you're tachycardia. Tachycardia, yes. Right. So we take a look at our big boxes. We see that the heart rate is about 150, 140-ish, okay? A couple other things?
Diffuse ST depressions? Yeah,
so we see, really, I think what you might be focusing in on is that we're identifying a right bundle branch block. We do also see some evidence of T-wave inversions, especially in leads 1 and 3. So let me kind of highlight a couple of things here. So we're looking at really right bundle branch block, tachycardia, and primarily some T-wave inversions in the septal leads V1, 2, and 3, not as much as pronounced in V3. So when you see something like this, what is something that in that acute dyspnea in this young female that we might be thinking? Throw out a couple differentials. PE? Okay, great, awesome, right? So I primed you guys pretty well. Some of the things that we want to focus on, right, with this right bundle branch block, with the tachycardia, with the septal ischemia, this is kind of signs of RV strain, RV dysfunction. That's one of the pictures that you want to get in your mind. And so when we go through EKGs, you have to be able to identify the key features that kind of create this morphology and these syndromes that kind of clue you into in a picture as to what's happening in the heart a little bit. So awesome, very good. So here's one more for that same patient. Name a couple things that we find on the EKG.
The Q3T3.
Okay, so I heard S1Q3T3. Anything else? So pretty big things that are in there, right? Those deep T waves, inverted T waves in our septal leads, V1, V2, V3. We're not quite seeing the bundle branch block. Our heart rate is kind of borderline at around 100, maybe a little bit of 100. And then we kind of pointed out the S1Q3T3. So just to kind of symbolize here, also another indication that we're seeing strain of that right ventricle, right? So kind of fits with our patient's differential with the pulmonary embolism. And in fact, of course, that is kind of what we're talking about. Now, briefly, when we talk about pulmonary embolism and EKGs, EKG is not a sensitive or specific test for diagnosing any type of pulmonary embolism. The reason that I bring this up is just because there may be other types of findings on the EKG. And before we jump to myocardial ischemia, acute occlusion MI, or other types of things, we need to take the context of the patient's clinical picturing. And then also, when you're getting an EKG for that person, are these kind of signs that I need to clue in? Do I need to dig a little bit deeper? Could this be something that's developing RV strain? Maybe this is more of a submassive PE, as Dr. Leafley was mentioning. The classic teaching is that the most common finding that we see on EKG is sinus tachycardia. It's not much more recent evidence, but more recent retrospective review that's actually probably a little bit lower incidence. but that's probably as an effect of we're overdiagnosing pulmonary embolisms, one with CTAs in the first place, and so that might artificially lower the incidence. Other things we can see are going to kind of focus on that right ventricle. So we're going to see either complete or incomplete right bundle branch blocks. We might see right axis deviation, especially in kind of a severe pulmonary embolism. Definitely RV strain patterns where we see some of the T-wave inversions here, primarily in the septal leads, along with that kind of pathognomonic S1Q3T3, which is often not present. It's pretty rare. You might also see a dominant R in V1. If they don't have a specific right bundle branch block yet, that can be an indication of RV strain. And so this R is not as elevated, but sometimes that might be a little bit more in V1, which I'm pointing out over here. And sometimes you see clockwise rotation, which we don't see as much in this, but clockwise rotation would basically be poor R wave progression here, with primarily really S waves over here and R waves up in the precordial leads, which is opposite of what we would see, indicating that the RV is having some type of dysfunction. Any questions about pulmonary embolism or those EKG findings? Okay. So we'll move on to case number 2, a 68-year-old male with dyspnea. And here is our EKG. So let me get a couple findings from the audience or anybody on Zoom as to what we see on this EKG. Okay, tachycardia.
Peaked P waves.
Okay, so we're seeing peaked P waves, you said? Absolutely, excellent. Anything else? A couple pretty big things. Speak up. So I think what you're talking about here in the precordial leads? Yeah, so what I would kind of term that more is what we talked a little bit before is the clockwise rotation. So we're seeing really only these S waves here in the precordial leads, and absent R waves at all here in the precordial leads. The other thing that I'm going to kind of point out, so absolutely excellent with the peaked P waves, right? This is going to represent that we're seeing some signs of dilation of the atria on the right side. And we're also seeing, and one thing that you often find, especially in these emphysematous patients or barrel-chested patients with very high residual lung volumes, you might see in the limb leads, specifically kind of one in AVL here, these very low voltages in reference to the rest of the entire EKG. And that kind of emphasizes the fact that we're seeing much more electrical activity primarily coming from this RV rather than looking at the LV, and we're also getting interference from that big difference of space of air in between the left side of the heart and the leads that we're trying to identify. And then we mentioned about the low voltages here. On the left side, we mentioned the absent R waves here in V1, 2, and 3. And these are kind of some of the classic signs. And also, of course, we have it's not specifically right axis deviation, but a more towards rightward axis. When we look at, there's this downward QRS here in AVL. All right. This one, I kind of gave it away a little bit. So here's a second one where we take a look at the same patient. So we didn't talk about the differential for this patient, who is a 68-year-old male coming in with acute dyspnea. What do we think could be going on based on the findings that y'all found on the last one?
COPD.
Yeah, COPD, absolutely, right? We're seeing evidence of right-sided pressures that are elevated, but specifically when we're seeing that the atria is pretty dilated and has a peaked P waves from there, we think that this is much more chronic, much more long-standing. And so someone who's 68 years old who's coming in with dyspnea, we might think that COPD would be more of one of our diseases that could be more prevalent. Other findings that we might see in patients with COPD, if we look down here, we take a look at the rhythm strip. We notice that, is this regular or irregular? Irregular, right? And then I've also kind of focused here on our P waves here in the rhythm strip. We notice that we don't have the same morphology of P waves present before each. So we have an irregular tachycardia with differing morphologies in P waves. What does that mean to you? MAT, right? Multifocal atrial tachycardia. You can also see other types of atrial tachycardia, such as atrial fibrillation or atrial flutter as well. MAT is kind of one of the more classic ones that we might see. The other thing that I have pointed out here is this dominant R in V1. So a couple high yield for dominant R in V1 that you want to think about is we're going back to the same concept of this right side of the heart, right? So we can see it in right ventricular hypertrophy or right ventricular strain, as we kind of saw in some of the pulmonary embolism. It could be the early signs of development of a right bundle branch block or part of the right bundle branch block pattern that we see. Sometimes in younger individuals, we might also see this. It could also be a normal physiologic pattern. We can see in hypertrophic cardiomyopathy, Wolff-Parkinson-White type A. However, with that, you would typically see the classical slurring of your QRS here, indicating that there likely is this early pre-excitation and possible accessory pathway. You could also see it in a posterior myocardial infarction. And also incorrect lead placement could lead to that as well. So kind of summarize for our COPD, some of the main findings that we'll find in a COPD patient when we get an EKG is that P pulmonale, that's the term that we identify as that very peaked P wave indicating the atrial dilatation. We also notice low voltage in the limb leads secondary to the either emphysematous changes or evidence of more predominant electrical activity on the right, RV hypertrophy, right bundle branch block, and RID. So it kind of makes sense where we have these pulmonary patterns. The things that we're going to be focusing on is the right ventricle. We're going to be looking at signs that are findings that indicate either something is occurring acutely, as we would see in the right ventricle, or maybe as we would see in pulmonary embolism, or maybe more chronic changes as we would see in COPD. And that's kind of to compare and contrast those two changes. Any questions either related on the pulmonary embolism EKG or the COPD EKG? Okay. So case 3. This is a 67-year-old female with, I'll give you a little bit more this time, hypertension, diabetes, and a prior TIA, coming in with hemiparesis, facial droop, and a slurred speech. So we have a pretty narrow differential more on this one, but let's take a look at the EKG. So some pretty stark changes here. Who wants to kind of characterize that for me?
Bradycardia.
Say?
Bradycardia.
Bradycardia. Okay, excellent. What else? T-wave inversions, right? T-wave inversions in 1, 2, V2, V3, V4, V5, V6, AVF. And we're also these pretty deep T-wave inversions that we see, especially in the precordial and limb leads. Very good. Those are kind of the main findings here. So what this really represents in the setting of the patient that we have, what do we think is highest on our differential from the story that I gave you in the EKG that we got? Stroke, right? So particularly when we take a look at this type of EKG, and when we think about strokes in general, you can often find a multitude of different types of EKG changes in stroke. This may be representative of a few different things we'll talk about kind of in summary. In here, this is what we kind of talk about as sometimes people might call this like a cerebral P wave. In all reality, this is an indication of increased intracranial pressure and the adrenergic surge that might go with it, right? We're seeing this bradycardia, we're seeing these deep ischemic changes in the heart. Really, we often are only going to see this in the later stages of an ischemic EKG, such as like a massive MCA, in which we're getting edema of the entire hemisphere, compression of the intracranial compartments, in which we would tend to see this. So hopefully you don't want to see this type of EKG in ischemic stroke. What you might be more likely to see is something like this, or any other type of ischemic pattern, especially if the person has underlying coronary artery disease, in which we have kind of that adrenergic surge from the ischemic event in the brain that's going on. So let's look at the second EKG and point out a couple things for me for this. Don't be shy. I'm going to call on somebody. Taylor. Yeah, you know. Some pretty obvious things.
Yeah, so P1, P2, and P3, you're seeing the S wave with ST segment elevation and T wave inversion.
Excellent. Absolutely. Right. So what would you be concerned about when you saw this EKG initially? A myocardial infarction, right? Anterior wall myocardial infarction. So the point of bringing this up is that we obviously get EKGs in patients with stroke. And one of the important things is our understanding of the etiological process of what's going on. So I'll give you a little bit more history about this patient. So we mentioned the right-sided hemiparesis. We mentioned had prior ischemic disease, TIA, in the past. So what if I told you that this person actually had chest pain about a week or 2 weeks ago, didn't really seek care or anything for it, and now showed up to the hospital with these stroke-like symptoms? Right? Yeah, absolutely, right? So this could be some persistent ST elevations, either due to persistent ischemia, or it could be due to persistent repolarization abnormalities present in a left ventricular aneurysm. This is not the exact EKG, but we actually had a pretty similar case like this last year when people were not going to the ER as much during COVID, and we actually had a pretty young gentleman who had a myocardial event, most likely at a basketball game the week before, didn't seek care, didn't think anything else, but it was pretty classical symptoms of an MI at that time. And then he showed up with a posterior stroke. And actually, on his EKG, he had these evidence of persistent ST elevations in V1, 2, and 3. And the etiology was he had a ventricular aneurysm that then led to an ischemic event. So the point of this is that actually implicates a little bit more about the therapeutic management of this patient. Okay, and so yes, we have stroke codes. Yes, we are looking at working with our neurological colleagues to identify an important thing, but we do have a significant role in making sure that we're evaluating for other etiologies as to what's going on. This kind of brings up the concept of the cerebral cardio syndrome. I'm not going to go into great little detail. That's a whole nother talk that's also been given on some in the past. But just history matters, and our evaluation of the patient, the etiology of the stroke matters. Okay, right, so biggest takeaway from if we think about ischemic events in the brain and looking at EKGs, huge variability. But it's not uncommon to see, especially with someone with underlying CAD, due to the adrenergic surge, it may demonstrate some type of ischemia. I talked about and mentioned briefly the cerebral cardiac syndrome. And then lastly, actually, I'll talk about that on the next slide. So any questions on the ischemic CVA? Okay. Case 4, a 72-year-old male with longstanding hypertension, EMS called due to collapse and decreased responsiveness. He had hemiparesis and slurred speech prior to arrival. And this is the EKG that was given on arrival. Does this look familiar to anybody? Who wants to tell me what it looks to them based on what I talked about earlier? Come on. All right, at least tell me a finding that you see. Okay, I heard T-wave inversions, right? T-wave inversions in 2, 3, 4, 5, 6, 2, flattening in AVL. Right? This is reminiscent of that increased ICP and cerebral P waves that I talked about on that previous one. So based on this, what would you think in the patient presentation that I gave you? What do you think is highest on your differential that came in? Yeah, subarachnoid hemorrhage, right? That fits everything, causes an increase in ICP, will give us this type of presentation on an EKG, and will also give us the presentation of stroke symptoms. All right. All right, here's the second EKG, same presentation of the patient. So I'm not going to ask about the T-wave inversions because we've already asked before, but there's one other big finding on here that may not be obvious right away, but if we take a look at it, specifically in the rhythm stricken, has to do with an interval. I'll give you a little hint. What do we see on here?
QT prolongation?
What'd you say?
QT prolongation?
Yes, QT prolongation, absolutely. We also see the T-wave inversions that we talked about from before, pretty profuse, especially in the precordial leads, along with a couple of the limb leads. And the QT is prolonged, right? Just by looking at it briefly, it's greater than half the R to R interval. And so one of the key points of just kind of bringing this up in context of everything else, so we talked about how this patient most likely has a subarachnoid hemorrhage based on presentation and history. But you also might find these ischemic looking EKGs in these types of cerebral events, whether it's an ischemic stroke, a hemorrhagic stroke, we can often see these types of things. Now, there's a lot of question as to the etiology as to why we see that, right? Do you have underlying CAD? Sometimes people don't even have underlying CAD and see this. They can get myocardial depression, they can get evidence of troponin elevations, but it may not necessarily be primarily cardiac related. And one of the interesting studies that I came across when I was looking at this is they were like, oh, this is due to the adrenergic surge. We're having stressing on the heart. Maybe this is related to kind of a Takotsubo's cardiomyopathy. Turns out actually it's not. A lot of the studies they did of this in Korea, where they cathed a lot of these patients ultimately, eventually, and did bedside echoes for everybody, where it did nothing kind of really correlated. So the main point of that is that you can often find a lot of these types of ischemic looking EKGs in intracranial events, but you need to take into the context of the patient, right? That's the biggest aspect of it. So obviously in an intracranial hemorrhage, some of the most prominent findings that would be the most concerning that we might see is ICP elevation stuff, such as the cerebral P waves that we talked about. Often it's ischemic, and of course, as I've emphasized over and over again, context and history of presentation of the patient matters. And we'll talk about this last case. So this was actually a case here at Kings County in CCT last week. This was a 27-year-old female with a past medical history of asthma and anxiety. I'll give you a little bit more on this one. And she collapsed in the shower. Family called 911. When EMS arrived, they noted that she was in an asystolic cardiac arrest with ROSC after 10 minutes and had cardiac arrest in the ER with ROSC within about a few minutes and one cycle of CPR after that. Now, I'll preface this with the next two EKGs are sequential from the same patient. And these are the real EKGs that we see. So I want someone to tell me the big findings on these EKGs. Okay, I heard diffuse ST depressions. Primarily we see 2, 3, AVF in our septal V2, V3, V4. What else? ST elevation and AVR. Excellent. It's a little bit hard to see here, but it is a little bit bigger than one box. All right, that's the main thing, a little bit tachycardic. All right, so what do we think is going on in this EKG? More importantly, what do we think occurred in this patient? As a reminder, 27-year-old out of hospital cardiac arrest. Who said that? Excellent. Why do you say that?
I think it's because most times AVR elevation during such depression is not regular.
Yes.
It's not ATS.
Absolutely, right? Context matters, clinical history matters, and we'll talk about in a second the implications of AVR elevation. But we also, most importantly, you can kind of see, we do not see any reciprocal changes that AVR would be involved, or that aspect of the coronary system would be involved. This is not specifically a coronary specific pattern. We're seeing kind of these diffuse changes, and some of these changes might actually be just more reciprocal to ischemia. This is the EKG that was performed immediately post-resuscitation in the ER, and it points out the findings that y'all talked about here. This is approximately 10 minutes after that other EKG, which shows absolute complete resolution of all of those findings. And so the biggest thing that we kind of talk about this, right? So we always get EKGs in post-cardiac arrest. one, I'm going to say again, context matters. And two, understanding the changes that might occur in a post-cardiac arrest EKG. Subal mentioned very astutely where we talk about the elevation in AVR. More often than not, this is going to be due to some type of either severe metabolic derangement, such as severe acidosis due to prolonged hypoxia and ischemia, global ischemia, severe hypoxia itself, severe hypotension of any etiology, massive hypovolemia, acute blood loss, all of that. The RV for many different reasons, and the right vascular seem to be the ones that tend to be affected most when all of these events occur. And so, of course, all this context matters. And we'll also kind of talk about a little bit that there's been more recently a good amount of studies, because obviously we talk about acute early intervention with PCI in patients who have an arrest that is due to a primary cardiac event. That's a whole nother lecture, of course, on itself. But there's a lot of study that has been performed in some prospective studies in which your EKG immediately, we're talking about within 5 minutes post-ROSC, may not 100% be reflective of the actual ischemic event that's going on in the heart. It depends upon the downtime, it depends upon the initial rhythm, what's going on, depends upon the clinical context. So the likelihood of this patient, of a 27-year-old having an acute myocardial infarction or acute occlusion MI as the etiology of arrest is not that likely, right? Unless there's some other kind of underlying history or things that we don't know that's going on. What's more likely is that this is findings that are present due to global hypoxia, either from the downtime itself or whatever inciting event that occurred. So Suvam actually kind of got it right. Unfortunately, her inciting event was a massive subarachnoid hemorrhage due to an aneurysm. And unfortunately, she had profound global ischemia and has a very poor prognosis at that point. One of the other things that I found interestingly enough was a retrospective review. So kind of take very grain of salt with this, of some people trying to find predictive clues or patterns in which you might want to say, should I get a head CT in this person who had an out-of-hospital cardiac arrest? I think it's an interesting question, which is why I found the article interesting. I do not think that their clinical decision-making tool is in any way validated or appropriate, but they often find these findings of global ischemia on the post-cardiac arrest EKGs more often than not in these patients who might have a differential that should include, should I image this person's head? So we, of course, don't have any basic elements. Some of the main things that they saw was almost exactly what we saw in our EKGs, these diffuse ST depressions, things that don't look like it's in a coronary event, taking that into a context of the patient in which the clinical history doesn't quite fit some type of myocardial ischemic event as an etiology as to what happened. So there are some studies that are looking into it, but the big takeaways of this is, our differential for AVR ST elevation. Of course, it could indicate some type of occlusion. It might represent some type of left main coronary disease or some proximal LAD stenosis. However, most findings have shown that usually it's not due to an acute occlusion MI. Oftentimes people have reasons for global ischemia of their heart, such as triple vessel disease or something that when stress occurs, we're seeing these types of elevations. But you, of course, can see an occlusion MI, and so context matters. And then lastly, of course, beware. I'm not saying you shouldn't get the EKG immediately post-arrest. That has not been formally studied. There is a lot of research into that, but just keep that in mind that there is almost an 18% incidence of false positives when we think about acute myocardial ischemia in early EKGs. And that incidence drops as you perform the EKG after about 8 minutes. So in conclusion, right, EKGs, we're going to be getting them on almost every single type of patient. It is not your main diagnostic choice in non-primarily cardiac etiologies, but it may tip you into clues if you weren't getting enough history, if you weren't getting enough other thing as to what may be going on in the underlying pathophysiology of the patient. And of course, context matters. I can't say it again. Understand that an EKG performed immediately post cardiac arrest may not be your best indicator as to see underlying what's going on in the heart. Any questions? All right. These are my references. That's it.